Welcome to our channel. Today we are discussing about chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, or COPD, is a progressive lung disease primarily caused by cigarette smoking, which accounts for 80 to 90% of cases. Environmental pollutants such as biomass fuels and occupational dust also contribute significantly. Genetic factors like alpha-1 antitrypsin deficiency increase susceptibility. Additionally, recurrent respiratory infections, especially during childhood, can predispose individuals to COPD. Understanding these risk factors is crucial for prevention and early intervention, as they highlight the importance of reducing exposure to harmful substances and addressing genetic vulnerabilities. COPD involves a complex interplay of inflammatory processes, structural changes, and airflow obstruction. The disease is characterized by chronic inflammation, oxidative stress, and a protease-antiprotease imbalance. These mechanisms lead to structural changes in the lungs, such as airway remodeling and alveolar destruction, resulting in airflow limitation. The loss of elastic recoil and dynamic airway collapse during expiration further exacerbate airflow obstruction. Gas exchange abnormalities, including ventilation perfusion mismatch and hypoxemia, contribute to the disease's progression. Understanding these mechanisms is essential for developing effective management strategies and improving patient outcomes. Chronic inflammation is a hallmark of COPD, triggered by smoking or other irritants. This abnormal response activates macrophages, neutrophils, and T lymphocytes, releasing inflammatory mediators like interleukins and tumor necrosis factor alpha. Oxidative stress, caused by reactive oxygen species from inflammatory cells and inhaled toxins, amplifies inflammation and tissue damage. The protease-antiprotease imbalance, with excessive protease activity overwhelming antiprotease defenses, leads to alveolar wall destruction and emphysema. These inflammatory and immune responses are central to the pathophysiology of COPD, driving disease progression and symptom severity. COPD leads to significant structural changes in the lungs, contributing to airflow obstruction. Inflammation causes airway remodeling, characterized by goblet cell hyperplasia, increased mucus production, and thickening of the bronchial wall, resulting in chronic bronchitis. Emphysema, marked by the loss of elastic recoil and alveolar destruction, further impairs airflow. Centriacinar emphysema, common in smokers, affects respiratory bronchioles, while panacinar emphysema, associated with alpha-1 antitrypsin deficiency, impacts the entire sinus. Small airway disease, or bronchiolitis, involves inflammation and fibrosis of small airways, increasing airway resistance and limiting airflow. Airflow limitation in COPD is primarily due to dynamic airway collapse and air trapping. The loss of elastic recoil and structural support causes airways to collapse during expiration, restricting airflow. Incomplete lung emptying leads to air trapping, increased residual volume, and hyperinflation. This condition raises the work of breathing, reduces diaphragm efficiency, and contributes to dyspnea and exercise intolerance. Understanding these mechanisms is vital for managing COPD symptoms and improving patients' quality of life, as they highlight the importance of interventions targeting airflow limitation and hyperinflation. Gas exchange abnormalities are a critical aspect of COPD, resulting from ventilation perfusion mismatch and hypoxemia. Alveolar destruction and capillary bed loss disrupt the balance between airflow and blood flow, leading to low oxygen levels. Chronic hypoxemia stimulates erythropoiesis, causing polycythemia and increased blood viscosity, further impairing oxygen delivery to tissues. Pulmonary hypertension and cor pulmonale, or right heart failure, develop due to chronic hypoxia and vascular remodeling. Addressing these abnormalities is essential for managing COPD and preventing complications, as they significantly impact patients' overall health and well-being. COPD presents with various clinical manifestations including dyspnea, or shortness of breath, initially on exertion and progressing to rest. Chronic cough and sputum production are typical of chronic bronchitis, while wheezing and chest tightness result from narrowed airways. Systemic manifestations such as muscle wasting, weight loss, osteoporosis, and cardiovascular comorbidities arise from systemic inflammation and reduced physical activity. Recognizing these symptoms is crucial for early diagnosis and effective management, as they significantly affect patients' quality of life and daily functioning. COPD can lead to several complications, including acute exacerbations, respiratory failure, and cardiovascular disease. Acute exacerbations, often triggered by infections or environmental factors, worsen symptoms and may require hospitalization, accelerating lung function decline. Advanced COPD can result in respiratory failure, necessitating oxygen therapy or non-invasive ventilation. Patients with COPD are also at higher risk for cardiovascular disease due to systemic inflammation and hypoxia. Understanding these complications is vital for comprehensive COPD management, as they significantly impact patients' prognosis and overall health. Effective management of COPD involves addressing its pathophysiology and complications. Smoking cessation is crucial to slow disease progression, while bronchodilators and anti-inflammatory agents help alleviate symptoms. Pulmonary rehabilitation improves exercise tolerance and quality of life, and oxygen therapy is essential for patients with hypoxemia. Understanding the underlying mechanisms of COPD guides these management strategies, emphasizing the importance of a comprehensive approach to improve patient outcomes and enhance their quality of life.